All right, so this is the last section for Firm. Yay! And then, there we go. Yeah, don't worry, you have a whole 2 more classes, 7 more credits in total of Farm to come. So don't you worry. Don't be here. This is the last section for at least the intro stuff. So today we're going to talk just about designing treatment regimens, kind of how you go about trying to go from diagnosis to how do I manage this patient, at least with as far as medicine goes. We'll talk a little bit about prescription writing as well, and that will inform your homework assignment that you'll turn in before the test, hopefully, right? Okay. So some things to consider. So we're going to talk about rational prescribing. I hope none of you will ever participate in irrational prescribing, even though I've certainly filled a few orders and scripts for some irrational seeming drugs in my time. So you guys are going to be way better than that. You're going to be perfect prescribers, I can tell. Once you make a diagnosis, though, what are the treatment courses? Like, how do you manage that patient? In some cases, it could be surgery, radiation, could be counseling, education, could be lots of things. One of the most common things you're going into, though, is medications, right? People, say you get a cold and you go in to see your provider and you leave and they say, hey, it's just a virus. Supportive care, just drink lots of fluid. Like, people feel like they kind of get gypped a little bit, right? They always want a prescription, they always want antibiotics or something. And so again, that's a case of irrational prescribing, as we'll see in just a little bit. But again, very often it does require a prescription, because again, you can recommend some over-the-counter stuff, but again, patients usually want the good stuff, right? So you usually need a prescription for a lot of that. So again, usually over 2/3 of the time, patients get prescribed medication when they come in for an office visit. Usually an average of 1 med per visit, typically. Could be more than that, though, depending on the patient, as you'll see. And again, this needs to be a stepwise approach about how we decide what medication is right for our patient, how we're going to dose it, how we're going to decide which one is even to use in the first place. So again, we'll walk through the steps on how we would do that. So again, step 1, you should probably make a pretty specific diagnosis. Now, is this always possible? Not always, right? You may not know specifically what's going on with your patient, but you try to make it the best guess you can using lab values and exams and all kinds of other stuff. However, patients oftentimes want you to do something, and that's why prescriptions oftentimes get written, even though they may not be totally useful all the time. And again, what happens if a patient just gets a prescription, even though they may not actually need it? Well, one, they have unnecessary costs could be associated with that. For instance, if I'm giving you, if I'm pretty sure that you have a virus, and I'm giving you an antibiotic script for that, and they take the antibiotic, you see things like resistance that can develop. That's why a lot of drugs like your Z-Paks and a lot of drugs like your Levaquins tend to lose efficacy over time, because now the bacteria are getting smarter and they're better able to fight off those antibiotics. And now we have these super bugs that are probably likely going to be, if it's not nuclear bombs from anywhere, then it's probably going to be the super bugs that will do us in as a society, if I had to guess. The thing is, it's going to be adverse drug reactions, right? So again, the more drugs you put on board, the more likely you are to have a reaction, right? So again, you typically want to have a tentative diagnosis on kind of to guide you on what the next step is going to be. So for instance, have a patient shows up, probable rheumatoid arthritis. Again, you probably want to share that reasoning why you think it is the case that I think you have RA versus anything else, right? So step 2, you want to consider what the pathophys of the actual disease state is. That's what you're going to get next semester in pathophys with probably Professor Lack or whoever else takes it. And so, knowing your pathophys will directly inform, okay, well, how do I want to modify that? What do I want to do from a medication standpoint to make this better for the patient, right? So again, knowing about RA, you learn that, okay, well, I know that, there's a lot of inflammatory mediators that are kind of propagating this inflammation that happens here. Well, maybe I can use something like a nonsteroidal anti-inflammatory drug. Maybe I can use something like an NSAID to combat the inflammation I know is, a hallmark of RA, right? Again, you make sure you're communicating with the patient, why you're deciding, well, why am I using this drug versus this drug? They may have heard of other drugs in the past. Why did my friend get this, but I'm not getting that? Why am I getting something different? And again, you need to make sure you're educating with the proper level for your patients, right? Because again, you may try to describe things like thromboxanes and prostaglandins to your patient, but if they don't have any kind of medical literacy, it's going to go over their head. And that's a quick way to lose people. So again, you want to talk about the appropriate level, right? There's a lot of good resources online, patient pamphlets that kind of speak down to, a relatively low grade level that can help people to understand this. The other big thing is do all your patients speak English? You have a high number of patients who speak Spanish, and again, if you're not bilingual, this is where a lot of online resources can be very good to help you along with that, right? So next, we want to select a therapeutic objective. So, okay, I know what the disease state is. I have a good idea what the pathophys is of the disease state. Well, which aspect of this do I want to attack, right? Which aspect of this do I want to try to modify? And so for the example of RA, the therapeutic objective I want to do is try to relieve the reduction of relief pain associated with this inflammatory process, right? So I want to have pain relief, and then the other goal would be to try to arrest the course of disease, right? I want to try to prevent the disease from getting any worse than it already is right now, okay? These are two different goals, and as such, do you think that needs two different meds? Oftentimes they do, right? So you may be able to get some dual benefit from one drug, but in a lot of cases you may need more than one drug in order to achieve all of your goals here. So in this case, I may need something like an anti-inflammatory that will fix one issue with the pain. However, I'm going to need something like a biologic drug that's going to be affecting the disease process itself, right? So I'll show you some examples of that in a minute. Okay, so next we want to look at our drug of choice. So again, more than one drug group for each of those goals may be identified, as the case may be. And again, you need to look at different specifics as far as to choosing a drug. So look at the age of the patient, other disease states they may have. So for instance, one of the things you'll find with nonsteroidal anti-inflammatory drugs typically raises blood pressure. Well, if my patient already has hypertension to begin with, that may not be the best choice for them, as the case may be. Look at other meds they're on. Obviously, always do interaction checkers to make sure that you're not going to be prescribing something that's going to be causing some deleterious effects to your patient. So in the case of RA, does the patient have a history of, say, aspirin intolerance, or they have a case of GI ulcers? Because I know that NSAIDs, or you will learn this, the NSAIDs can potentially exacerbate peptic ulcer disease, right? Is cost a major issue? Does the patient even have insurance? What type of insurance do they have? If you work with a lot of Medicare or Medicaid patients, you'll know after a while kind of what the normal formulary is for those type of patients. You'll learn based on insurances and what you're expected to cover. And then looking at things like, is once daily dosing important? Do they have memory issues to where doing things more than once a time a day is going to be a problem for them? Those are things you all have to consider, right? Next, look at your appropriate treatment regimen. This is typically dictated by the kinetics of the drug. So how often I have to give a drug, even what formulation, if I give extended release or immediate release, is all important here. So again, look at the organ impairment. Do they have poor kidney function? One of the other things you'll find is that NSAIDs can actually decrease kidney function. So if they have chronic kidney disease, it may not be a good option for them again. Should I change the frequency? Should I change the dose? Right? Those are all things organ function can kind of inform here. And again, what's the patient going to be able to tolerate? How many times a day are they willing to take it? If they're like, man, I have to take a drug 6 times a day, that's just too much for me. I got too busy a schedule. I'm not going to do that. Find someone who's going to be able to fit with their schedule a little bit better. Right? Then look for a plan that's going to be monitoring for the drug's action. Try to determine what your endpoint of therapy is. So for instance, if I'm dealing with pain, what might my endpoint be for the patient? To be pain-free, maybe. That would all be the ultimate goal, right? Is that always going to be the case? Can I always get a patient pain-free? Oftentimes, no. But what's an acceptable pain reduction for them? If they constantly are living at, say, a 6 out of 10 on a 10-point pain scale, maybe getting them down to a 4 is going to be a great improvement for them, or getting them down to a 3. Maybe that's all you can do with current medications. And so that's an important thing to set goals with your patient. Again, look at the know what drug effects to monitor for. Specifically if I'm using an NSAID, I'm looking for things like kidney function. I'm looking at things like GI, if they're having any kind of GI ulcers forming their symptoms consistent with that. Laboratory testing if I need to draw certain labs because of the drugs I'm giving. Those are all things you want to know about. And again, look at the rational. Or explain why you're going to be using a drug as long as you are. For instance, with antibiotics, I say, okay, we'll take this antibiotic for 10 days. And then when do patients usually start to feel better when they start antibiotics? A couple of days, yeah, like say 3 or 4 days, right? They start to feel better, and then they say, okay, well, I must be better. Why do I need to take all this extra drug? Well, you need to describe to them why they should do that, because again, you need to make sure you get rid of all the bacteria that are causing the issue. Otherwise, what can happen? Resistance, or they may have the infection actually come back and be worse than before, right? Now I have to give them a different antibiotic to treat these new resistant bugs. So again, explain, okay, well, you'll feel better after a couple of days, but you need to do the full course, okay? In order to make sure they understand that sort of thing. Or this is going to be a lifelong drug. Explain why it's a lifelong drug, because again, no one outgrows RA. It's going to be something that they're going to be living with the rest of their lives potentially. So these are things you have to kind of explain. And then again, also explain what would be constituting a need for change in therapy. So for instance, if I give a patient an NSAID, what would be these kind of warning things I'd want them to know about in order to know to come back to me in order to get a different drug potentially, right? So for instance, if they notice dark, tarry stool, and we know what that's indicative of? GI bleed, right? So again, usually an upper GI bleed, that would be a warning sign. That would be something like, oh, that's not normal. We should probably get you off of this medication on something else. It's evidence of maybe a peptic or a gastric bleed. Yeah, if they're throwing up blood, like those are all kind of warning signs. It may not be that specific. It may not be that kind of obvious sort of red flag there, but let them know. Okay, well, if you start to notice these things happening, that's when you come back and talk about a different drug for your disease state. Okay, and again, try to come up with a plan of education. Again, the most important thing you're going to do with your patients is educate them. Make sure you're looking at things like age barriers. If I'm talking to a 2-year-old, I'm not going to be able to educate them a whole lot on why we're doing the antibiotics we're having to give them, why they have to take this really nasty tasting stuff. However, talk to the parents. Parents also may not be at a very high functioning level depending on who you're dealing with, but again, make sure you bring it down to their level. Look for educational stuff, language barriers. Again, frequently we have a lot of patients who come from other countries because again, we are a big travel hub here, so you have a lot of people coming from South America and Europe and different places, and make sure you're kind of dealing with the language barriers there. Oftentimes we have devices that kind of help us out. It's like an iPad. It has like a translator service. We used to call it Johnny 5. But basically, take it into the room and you like hook up with a translation service, and basically you have a person, kind of describe what you're talking about. They translate it back and forth, and so you have your resources like that you want to use. Make sure you use educational materials whenever you can. So, for instance, here's a drug called Diastat. Whenever familiar with Diastat? It's actually a rectally administered drug we use for seizures. So if you have a child who has a seizure disorder, they start to have a seizure, you can administer this drug rectally. Well, that can be pretty tough to do if you're dealing with it first time, if you've never had to give the medication before, and you get the kids seizing on the floor, that can be a little harrowing of an experience. So you want to educate them beforehand. Okay, here's what you got to do. Make sure you take their pants off, and here's the lubrication packet that comes with it. Make sure you lube this up, otherwise it's going to hurt afterwards. Things like that. Make sure they administer the drug appropriately. Okay. And so other things, pharmacies typically will provide this drug information. However, do the pharmacists have like hours and hours to spend with the patients? You can't guarantee that sort of thing, right? They get pretty busy too. And so you want to make sure you take time to explain to the patient, because again, you want to make sure you're not an additional hole in that Swiss cheese I kind of mentioned where errors can occur. Remember that analogy I made? You do want to be one of those holes, right? Again, don't assume they're going to explain to the patient. I would like to assume that all pharmacists are going to do their best and talk to every single patient. However, I know the realities of things, and CVS's and Walgreens, they might not just have the time to do it, which is, again, no excuse. However, it's just the reality. Okay, so let's look at an example of a rational prescribing. Let's say we have a 3-year-old patient who presents with left ear pain, have a fever of 101.3, have cough and runny nose, and then we take a look at their ear and we see this. So what do you think? Yeah, we're going to think there's probably something going on, probably an infectious process, probably say acute otitis media. Again, we're going to make a specific diagnosis in this case. We can, again, based on clinical findings, we can be pretty well assured this is acute otitis. Okay, and again, at this point, you want to be able to explain to the family, okay, do I think this is bacterial? Do I think this is viral? And that will inform like whether you're going to be treating or not, or what drugs you're going to use. In this case, probably going to be bacterial, so we're going to go ahead and use something like an antibiotic to treat that. Now, do I want to use an antiviral? Probably not if I think it's bacterial, right? So again, you have to kind of hedge your bets on what you think is most likely to be the etiology there. Okay, so next we're going to consider the implications here. So again, you have to know, okay, well, based on the pathophys, I need you, especially for infectious disease stuff, what are the most common bugs you're going to be dealing with? So in this case, I know for acute otitis, the most common things I'm going to see are things like strep pneumo, things like H. influenza. You're going to become familiar with these as we go forward, so don't worry if you don't know all this stuff already. Just know this is what you're going to run into in upcoming semesters. And this actually helps tailor our antibiotic therapy, because again, I don't want to use a drug that's going to treat every single bacteria out there, because again, that's ineffective, inefficient. I want to use something that's going to be more laser targeted towards the specific bugs I think may be causing this patient's acute otitis, right? So again, I want usually something that's going to be more specific for that. And again, provide this information to the parents, but hey, this is why I'm using this antibiotic, because I think they have a bacterial infection. I think this is the most likely bug, and this is why I'm giving this drug for that, right? So that way they're not like, well, you gave my friend a Z-Pak, last week, or so-and-so in my family got a Cipro for their infection. How come I'm just getting amoxicillin? These are things you can explain based on knowing the disease state, knowing the pathophys, et cetera, right? So again, lots of resources that are out there, like CDC is really good for like infectious disease stuff. You can find all kinds of good information out there. Guide the parents to this. They can look it up and kind of educate themselves as well, right? Okay, next we're going to try to select a therapeutic objective. If we have a bacterial infection, our objective should be get rid of the bacteria, right? So again, we need to kill them off. And so how are we going to do that? Make sure we're using appropriate antimicrobial coverage, right? So I'm not going to use an antibiotic that doesn't hit strep pneumo if I think that's the most likely bug to be the causative organism here, right? And then a goal 2 would be maybe treating sequelae of the disease. So for instance, they came with fever, maybe I want to give them an antipyretic, right? Give them something for their fever. Again, can I use the same drug for both of these? I mean, eventually the antibiotic will deal with the fever because they're not infected anymore. However, not in the meantime, right? So again, oftentimes you may use multiple drugs to get multiple goals satisfied there. All right, so next we're going to select a drug of choice. How do you determine what the drug of choice is going to be? Just kind of throw a dart at a board and see what you land on. You get clindamycin today. You get oxycodone for acute otitis media. No, you got to go with your guidelines, right? You're going to know based on, you're going to go to your resources. You're going to go to things like UpToDate. It's going to give you information. Okay, this is the disease state. This is the likely organism. This is the drug of choice based on that, right? So again, also looking into things like, well, look at the age of the patient. That can affect, what kind of dose you're going to be giving them. Look at organ function. Look at allergies. Obviously, if they have an allergy to penicillin, I probably don't want to give them penicillin necessarily, right? Or look at their previous or concurrent medications. A lot of times, especially with infectious disease stuff and little kids, they're getting multiple courses of antibiotics. Frequently, that can lead you to think they're more likely to be resistant. It may change which drug you use specifically because of that, right? They're more likely to have a resistant bug. You use something like a bigger gun, a bigger antibiotic, right? And of course, use your appropriate resources here. So again, if I had to tell you to go look up the drug of choice for acute otitis media, where might you go? Any ideas? WebMD, possibly. They could have some links to the guidelines potentially. It could be one. Of course, anything you put into WebMD always comes out cancer, so I don't want right? And the sniffles, you're going to die. Sorry. Okay, so you're going to learn all about these resources. You're going to find that lots of different drug references exist out there. Most of you will probably end up downloading Hippocrates at some point onto your phones because, again, it's free and most people go to that. It's not my favorite reference. I have some issues with it. However, a lot of people still use it. But if, again, you guys are familiar with UpToDate? You heard of UpToDate yet? When you go to the library website for Nova, go to UpToDate. That's going to be one of your most visited websites while you're in school, I can guarantee you right now. But they are owned by the same company that owns Lexicomp. That's actually my preferred drug information resource. And actually, if you Google, I'm sorry, not Google, if you search in UpToDate for a specific drug, it'll actually link you back to Lexicomp. It's and it will give you all the information you need on a particular drug. Other references that are out there, things like Micromedics, clinical pharmacology, these are all available through the Nova website. So you can actually look that up on their databases and get access to that. And then there's actually infectious disease specific books out there. So anyone heard of the Sanford Guide? Is one you're going to use very frequently with infectious disease stuff. They put out a new one every single year, and they give you these nice big charts you can go through and say, okay, I'm dealing with acute otitis media. Here's the age of the patient, no allergies. Okay, this is my drug of choice. Boom, it's right there. Because again, you want these references to be quick and easy, because again, you're seeing a lot of patients. You want to be able to find this information very quickly, right? Even specifically for like peds infectious disease, there's what we call the Red Book. It's a standard reference we use for a lot of peds infectious disease stuff, and then also visit your guidelines. Those are always going to be usually the most up-to-date, most recent recommendations as far as how to treat different disease states. So for instance, if I was dealing with an acute otitis media in a child, like a 3-year-old, I'd look at places like the Infectious Disease Society of America, right? Look at American Academy of Pediatrics. Again, you can usually just go to Google and type in acute otitis media guidelines. They'll probably bring you to one of the right places, right? So again, your Google foo will serve you well in medicine. Again, don't use it as your only resource, but Google can help quite a bit. All right, so next we're going to select a drug of choice based on our references here. So again, we're looking at things like how often is the drug going to be given? Are there different dosage forms available? So for instance, with a 3-year-old, what kind of dosage forms do you think I can use? So can I give him a tablet? Probably not. 3-year-old's probably not going to swallow a tablet. However, so I need to look to see if there's liquid dosage forms that are available for them, right? If they can't use that, I've had cases where kids come in for an acute otitis media, they can't take anything orally because they're so sick and vomiting and all these issues. So we have to give them intramuscular injections, right? So again, what drugs would fall into that category? So those are things you have to consider. What dosage forms are appropriate? Are there drug shortages? Maybe the drug of choice you want isn't available at all. You can't really get around that. And then looking for things like, how much does it cost? Will their insurance cover it? If not, is there a free antibiotic option, right? So potentially you go to like Publix or somewhere, there's a certain list of free antibiotics you can get a hold of that may really guide your decision on what antibiotic to choose there. And then also look at the palatability. So again, if a patient thinks it's so gross and they keep spitting it out at you, they're not really going to get good bioavailability in that case, right? So again, maybe look at flavoring it or whatever options you have there. Okay, so these all go into your decision on what drug you're going to be administering. So next we're going to decide the appropriate dosage regimen. So here's a little screen grab from one of the guidelines for acute otitis media out of the American Academy of Pediatrics. And so here they actually give you a recommended, and they have these nice tables that gives you all the information you need right there. It says recommended first line treatment, amoxicillin, 80 to 90 mg per kilo per day in 2 divided doses. And then, okay, well, the patient's allergic. What could I use instead? Okay, maybe I can use something like Ceftonir. And again, they give you all the options here, so that way you can say, okay, well, based on my patient, I think this might be the best drug for them. Okay, so again, you're going to find this in all kinds of guidelines. You find information like this in UpToDate. It's all readily available to you. Okay, so let's say we go with amoxicillin, our drug of choice for acute otitis media. We know we're going to give 90 milligrams per kilo per day, divided twice daily. Right, so then you have to figure out, okay, well, how does the drug come, right? For a kid 3 years old, probably want to use a liquid suspension. So I'm going to use the suspension comes at 400 milligrams per 5 mLs. problem similar to this may be showing up somewhere like on your prescription assignment, perhaps. I don't know, maybe, we'll see. Okay, so let's say, the patient weighs 20 kilograms. The question is, well, how many mLs would they need per dose? Do I have all the math on the next slide? I don't remember. Yeah. Fantastic. All right, so let's say we have our dose here is 90 mg per kilo per day divided twice a day. The suspension comes as 400 per 5, as we said, and the patient weighs 20. So again, how many mLs do they need per dose? Basically, we're going to do that 45, because again, basically just do that 90 and divided by 2, right, to get the amount I need per dose instead of per day. So 45 times 20 equals 900 milligrams per dose. Okay. At this point, then I'm going to take that 400 divided by 5, so I know that per ml, my amoxicillin comes as an 80 milligram per ml concentration, and I just take 900 divided by 80, and guess what? They're taking 11.25 mLs. How often? Yeah, they would take that twice a day, right? So again, I could have not divided by 2 in this first case here. I would have gotten basically double that, so 22.5, and I just would have divided that by 2 to get the final amount they need, okay? So again, a lot of times you're working with electronic medical records where they will do the math for you. May not always be the case depending on where you're working at. Maybe the computer systems are down. You may have to do this by hand. So this is why I try to drill this into you this early stage of your career here. Okay, so next we're going to try to determine, what's our monitoring plan? How do we determine whether the drug is efficacious or not? So how might you think for, an infection like this, how can I determine if the patient's getting better or not? Maybe their fever comes down, maybe their ear pain is less, or having drainage, maybe that's clearing up. The patient just looks better, essentially, right? So there's things to monitor for. Again, with antibiotics, you may tell them, hey, look out for things like diarrhea. Look out for things, if the patient's not getting any better over the next couple of days, come back, we may need to use a different antibiotic. And do things like explain why we need to treat for the full course, and why we need to treat for a full 10 days as opposed to 7 days or 14 days. Like, why 10 days is best? Because we know that based on the guidelines, this is what they recommend, right? And then again, what would constitute a change in therapy? Obviously, the patient has throat swelling. That's probably not the best drug for them, right? Or if they fail to improve over the next 2 or 3 days, maybe they should come back and get something else. Okay, so these are all things you're going to explain to the patients, or the patient's parent, as the case may be. Again, look at educational barriers, language barriers, try to get around those. Again, every place will usually have resources that can help you out with this. Okay, so that's the rational prescribing sort of the way of just going from diagnosis all the way to kind of deciding what drugs are going to be best for them. Let's talk about prescription writing real quick. So what is a prescription? Basically, we're writing down something. It could be verbal, it could be an electronic order, but basically we're doing something. In this case, we're going to focus on drugs, but it's something being fulfilled by the pharmacist, right? So again, I get an order for amoxicillin, 11.25 mLs twice a day. I'm going to figure out the volume I'm going to administer and say, okay, well, this is what the patient needs. I dispense that to them, right? It's the job of the pharmacist. Now, who can prescribe here in Florida? Certainly physicians can. Who else might be able to? PAs, yes, absolutely. Otherwise, I wouldn't be teaching you guys this stuff, right? Who else? Nurse practitioners, absolutely. Podiatrists, vets, optometrists. There's lots of different people that can prescribe, prescriptions, right? So again, it all just depends on who the provider is. And again, we get all kinds of weird. One time I was filling a prescription for, it was enough cephalexin or Keflex then about to kill a moose, basically. And I was like, who in the heck needs this much Keflex? Oh, it's for a Burmese mountain dog. So sometimes you have to fill stuff from, different providers, and some of the vets are one of them, but. Anyway, so one of the things you'll note is that there's always going to be a set of state laws and there'll be a set of federal laws. And again, the question is, well, which one do you go with? And typically, you're going to go with whichever one tends to be more strict, okay? Or if it's not addressed in federal law, go with the state law. Or if it's not addressed in state law, just go with the federal law. So again, typically you'll find you're going to go with whichever one tends to be stricter. You can't really go wrong by doing that, right? By satisfying the federal law, you can't really break the state law, essentially. Make sense? Again, all prescriptions should be legible. I've learned to read some pretty bad handwriting, however. Again, most of the time it's not an issue because most prescriptions are electronic nowadays, but try to be legible whenever you can. Try to be unambiguous. Be very clear about what you're actually prescribing, so that way the person's filling it, they know exactly what to do, right? They try to follow your order to the letter as they can. And again, make sure you provide enough information. That way we can try to help other people not cause medication errors that happens here, right? So we can just discover errors. So for instance, if I just get a script for amoxicillin and I don't know the age of the patient, that doesn't really help me out very much, because I can't determine is this too much, too little, and that's one of the things that we do as pharmacists to try to determine, is this dose appropriate for the patient? So I need kind of more information. That's what can be provided on those scripts. So looking at the law here, so this is the Florida statute. This is basically what we follow when writing prescriptions in Florida. And again, I know not all of you will practice in Florida, but I can make a safe assumption probably the majority will, so let's go off of this. And so this is the basic requirement for non-controlled substances. Does it say non-controlled? Anyone know what that means? They're prescription drugs, so again, aren't they all controlled? Not really. Controlled substances are basically drugs that are at risk for being abused. This includes like your opioids. This includes things like Adderall, like your other ADHD meds. Those are controlled substances because there is an abuse potential. People could potentially become addicted to them, and we have a tighter control on those. So, you know, if it's your blood pressure medication or your diabetes medication, those are non-controlled substances, right? These are non-narcotic substances that we're talking about here. These have the least amount of control around them, besides the fact they're just prescription drugs, right? So again, basically look at the requirements, and if you look at the rubric that I have for the prescription writing assignment, you'll realize that we follow all of these, right? And again, my assignments are probably going to be more strict as far as what I'm looking for. Again, you may find when you're practicing, you do something a little different. However, I figure as long as I'm getting you guys as strict as possible now, you can defer off of that later on if you need to, or kind of veer away from that as needed. But again, you can't go wrong if you follow this sort of method here. So anyway, the things that are required to be on a script includes basically be legible. You had to put that in the law because, again, a lot of people write illegibly. The name of the practitioner, so your name has to be on the prescription. The name and the strength of the drug, makes sense. The quantity of drug to dispense. This is one of the big things that a lot of people get wrong when they're writing prescriptions, at least in your early stages, is not figuring out the right quantity to dispense. And typically, how long are we dispensing for? So imagine it's like an antihypertensive drug. Usually 30 days at a time, right? Or for instance, if you're doing antibiotic for 10 days, you write for a 10-day supply basically. So if you're taking one pill one time a day, the dispense quantity would just be, well, I imagine we're doing like a continuous treatment. You just write for 30, right? You usually write for a month at a time if for a medication is going to be continuous, right? If it was an antibiotic that's one time a day, then I write for the 10 in that case if it was 10 days, okay? So again, make sure your prescription makes sense based on the dispense quantity there, because again, that has to be on there. Otherwise, if we see a discrepancy there, we're going to give you a call, right? And again, the biggest thing I want you guys to get out of my classes is to have as few nerdy pharmacists calling you as possible, right? So again, as few errors as you can help. Anyway, so again, quantity needs to be on there. The directions for use, what does this mean? Yeah, take one tab once a day, take 3 mLs twice a day by mouth. So that's an important thing. You need to have the route on there as well, right? So again, it's not just enough to say take 1 tablet a day. You want to be specific and say take 1 tablet PO or by mouth once daily, right? So that way you include the route, so that way it's very clear. It may seem like a no-brainer for things like tablets and whatnot. However, there are vaginal tablets. You know, there are liquids that may be given via other routes. You want to be specific. The more specific you are, the less likely you can have an error that can occur here, right? Okay, it should be dated. Again, you don't want to like pre-sign a bunch of prescriptions. That's kind of a no-no, but it needs to be dated on the date you wrote it, and then it needs to be signed. Now, again, I mentioned no pre-signing, but you know, can I use a stamp? You can use a stamp. Yep. Can I electronically sign it? Absolutely. You can handwrite it yourself. Again, for non-controlled substances, any of these are fine, right? Because again, I can call in a prescription potentially. Again, there's no signature on there, but the pharmacist will still take that down, put your name on there or whatnot. But again, that kind of counts as like a verbal sort of signature in those cases there, right? And again, I mentioned this can be called in, communicated electronically. Again, a lot of scripts are just sent via fax. That's no problem. That's done very frequently. We'll talk about some exceptions where that cannot occur. Okay, we'll see. And then one rule for non-controlled prescriptions, they're all good for 1 year. Okay, so you can write, I'm going to write for, you know, say 30 pills, so I'm going to take 30 pills in a month, and I can write for 48 refills, right? So 48 months worth, but again, after 12 months, that prescription is no good, and they need a new one. Okay, so that's a general rule for non-controlled substances. They're only good for 1 year. Okay. Okay, you can put multiple scripts on the same prescription paper. That's totally fine. For my assignment, I'm going to have you just put them on different ones, so that way that way you're not trying to scrunch in a bunch of information onto one. It lead to the errors. So again, we'll keep them on separate here, but you can't put multiple non-controlled substances onto one prescription there. Okay, we'll find that controlled substances need to be separated, and C2s need to be by themselves. I'll talk about what a C2 is in just a few minutes here. Okay. All right, so for example, this is what a good script would look like, and it looks probably pretty similar to the rubric and the example I included there. So again, it includes the name of the clinic. Notice here it also includes information on how to identify the prescriber, right? So for instance, the license number, the DEA number, which again, this is going to become mandatory when you're writing for a controlled substance, but a lot of people will include this anyway, because it's just an additional way to identify the prescriber. MPI number will usually be included there as well, and then usually where you're working at, and then contact information, right? So you'll have, you know, the location, phone number to get a hold of the people there. So some things you notice here, did I require a date of birth on the prescription? Was that listed as a requirement before? It actually wasn't. So what's the benefit of adding in a date of birth?
identify that's the right patient.
Yeah, you want to be able to identify it's the right patient. So Sean Martin, there could be a lot of Sean Martins that are out there. There's a lot of John Does out there, John Smiths. So because of that, you need to make sure you can identify them based on their address, based on their date of birth. Usually date of birth is the most common one's going to be on here, but you may also include the patient's address. You're going to find there's going to be some cases where that's going to be mandatory, but if again for a non-controlled substance, that's not mandatory, but it's a good habit to get into, right? So again, a lot of things I'm going to be teaching you are just good habits and may not necessarily be required by law. Okay, so again, the date the prescription is written. A lot of times people include allergies if present. Otherwise, just write no drug allergies. That can be useful as well if you're filling a prescription and if you're not familiar with the patient from the pharmacy standpoint. And then they write the name of the drug itself, so metformin, glucophage. It's not necessary to write the brand name in there. You can just write the generic, and that's going to be okay. But however, this is good because it helps us to make sure we're not getting drugs mixed up potentially, right? They write 500 milligram tablets. And they're actually writing the dispense number right here, so they write for number 100. Okay. Yes, sir.
When you do the quantity right there, dispense 100 number and spell it out, or is the number fine?
You don't have to put that. You don't have to actually spell it out on the non-controlled substances. We'll look in a second at the differences there, and those you do need to write it out. Because again, imagine if I write for say if I was writing for oxycodone for a patient, I wrote number 10, right? So just hashtag 10. I don't know why I'd say. I guess we're all saying hashtag nowadays, but anyway. Number 10, and I did not write it out in actual textual information TEN, what could the patient do? Add a little 0 into there and then give a little extra for Papa, right? You know, so lots of nefarious things can happen when it comes to controlled substances, and you want to try to prevent that. So by writing that out textually, again, that's a good habit to get into. So writing 30 in parentheses would be totally okay. Yeah, more information is better than less. So in this case, we're for number 100. Again, looking at the directions, taking 1 daily for controlled diabetes. So you notice here the instructions are taking 1 daily. They didn't include PO. I would like to see that included on there. Again, route and being specific is always good. And again, I'm going to be giving you guys different types of scripts as we go through. Some are injectables, some are going to be rectal drugs, it can range. So you need to make sure you're including the route just to be specific, right? So you could take 1 tab, PO daily, or by mouth daily would be totally fine there, okay? And then you notice here for controlled diabetes, that's the indication, right? So again, that's also a good thing to include because you may find drugs have multiple indications. So for instance, I may give metformin to a patient for polycystic ovarian syndrome, right? Has nothing to do with diabetes. So I might get that script, and if it didn't say anything, I'd say, well, this is like say a 26-year-old female, looks relatively healthy, like you don't have diabetes, and then we have to kind of figure out more information. And it's good because then I can compare it to the other drugs I may be on to see if there's any kind of interactions that are happening there. So again, including the indication, I will require that of you guys, but that is not an indication. It's not required by law. Okay, but again, it's good practice. So anyways, we have the quantity, have directions, we have the indication, we have the number of refills to include. If you don't put any, we'll just assume it's 0, but again, you want to include any refills there. And so you notice we're giving 1 tab daily. What's the dispense quantity we're doing? What's the duration there? It's like 3 months, right? So again, roughly, you can write 90, you could write 100. The thing you'll run into though is that some insurance companies may not want to pay for more than a month at a time. That's all very dependent. So for instance, if I got a script like this and the insurance company said, hey, we only want to do for 30 at a time, we would go ahead and make sure that that whole quantity the patient can get throughout the year. Because ideally, if they're getting 100 in a go and they have 3 refills, that should cover them for the entire year, right? So they get the original fill and then they get 3 additional refills from there. So that should cover 12 months. However, if the insurance company didn't want to fill that out, or you give more than 30, then we would take care of that on our side. So you don't have to really concern yourself with that so much, but include how many refills you want to include there, right? And then your signature should be included there as well, just to finally make it all official, right? Okay, so that's generally what a good prescription would look like. Okay, so reasons why we have prescribing errors that occur, oftentimes is due to omission of information. So for instance, if I have a patient, say, going to surgery, they come out and I say, hey, resume pre-op meds. What are you talking about, right? You need to make sure that that information is very specific because maybe there's a med you didn't consider that you actually don't want to get restarted, right? You need to go through and actually do an appropriate med rec anytime the patient changes levels of care like that, either going to surgery or from surgery, whatever it happens to be. Or continue present IV fluids. What are you talking about? Is it normal saline? Is it NS with D5? We need to know that information, okay? So again, be more specific. The more specific you can be, the better, okay? In some cases, you may find errors that can occur where patients will get started on a new med and not get the information. They should have discontinued the old one. So that can be an error that can pop up with some regularity. Again, if they are hearing a bunch of stuff, they may not actually get all the information, which is why it's good to have that teach back sort of method with your patients. Other things may not include whether the drug is short-acting, long-acting. That can be a problem, especially with drugs that have very different dosing regimens based on that. So, for instance, the one that I always run into is Wellbutrin. Wellbutrin is an antidepressant drug. There's an SR formulation that's twice a day and an XL that's 1 time a day. If the nurse did the med rec wrong, and then the provider orders it wrong, then that dose is very different. The how often we're giving is very different. I want to make sure I'm doing exactly what the patient was on beforehand, right? So again, always indicate that sort of thing. And then what's the abbreviation for as needed? Yeah, PRN. So again, if you ever write, say, let's give this PRN, you want to include what it's specifically for, right? So that goes back to that, including that indication. So again, if I give a patient Zofran because they're having nausea, vomiting, I want to say PRN, nausea and vomiting. Okay. You want to give specific instructions so that way the patient knows exactly when they should take the drug and not just take it whenever they decide to, right? This is also good on the inpatient side as well because that way nursing will know when they should give a drug versus one versus another. So for instance, we had a big issue with this with Joint Commission, right? Joint Commission is the people that accredit the hospitals essentially and let us keep getting money from Medicare or Medicaid. We had an issue where we would write, for multiple pain meds for the same patient, they'd have oral Tylenol, which is kind of a wimpy analgesic. We'd have, say, an oral oxycodone, which is a pretty good analgesic, and then IV morphine. They'd all say PRN on them. Well, how does the nurse know which one to give? If she's making an independent decision on that, guess what? That's independent practice. That's outside of her scope. So we had to go through and say, okay, well, for pain scale 1 to 3, Tylenol. If you're pain scale 4 to 6, you're going to give oral oxycodone. If you're pain scale 7 to 10, you give IV morphine. That way the nurse has a good indication on what to give. Okay, so again, anytime PRN, include an indication afterwards, right? And again, don't write like this. Please be as legible as possible. And again, you may have to write a handwritten prescription every once in a while. I mentioned, did I talk about the ER doc that I had when the system went down? So basically, I had a PEDS-trained emergency medicine physician I was working with, and she was relatively fresh out of fellowship, so she was relatively young, and our computer system went down. She's like, well, I need to write a prescription. I said, okay, well, here's the paper. Go ahead and write it. She's like, I've never handwritten a prescription before in my life. So, okay, well, let's go and work through it, and here's all the steps you have to do, just like I'm doing with you guys now, so that way you all already have an idea of what to do. Again, handwritten prescriptions still come through every once in a while. Okay. Some other types of prescribing errors you can run into. Looking at misplaced decimals, you always want to make sure if you have a decimal place you're putting there, always have a preceding 0, right? So for instance, if I just write 0.1, that can be misread as 1. It's a big difference, a 10-fold difference in dose you can see with that. So again, you got to be careful with that. And then having unnecessary zeros is also bad, right? So for instance, if I write 1, but I put a 1.0, that can be misread as 10. Again, it's another 10-fold overdose in those cases. You can be very careful with your decimals. Do not have trailing zeros. You always typically want to have leading zeros. You have a decimal point there, right? And then misreading things is like U as a 0. So for instance, insulin is dosed in units. So if I write 10 U of insulin, that can be misread as 100 units. And it seems silly when I have it like in electronic text right here, but if you were to actually write it down, you can see if you're going quick how that could be misread, right? So again, if I gave someone 100 units of insulin and I only meant to give 10, they're going to have some issues there, right? So again, always write out the word units. I'm not going to have you guys write, usually it's, if you ever see IU, it stands for international units, just write units. I don't really care to write the international for my purposes. So just write out units textually, okay? Okay, some other type of errors you can run into. So again, if you write like a microgram is like UG, that can be misread. So usually I'll just write out MCG. If you're writing for micrograms of a drug, so that's again less likely to be confused. Never, ever, ever use QD. QD stands for what? Every day. That can be misread as sometimes QID if you're writing too quick. So again, QID is 4 times versus 1. It's a big problem. Always write out daily. Okay, so you can just say take 1 tab once daily, take 1 tab every day. Whatever happens to be, don't write QD. It's a big no-no. Again, the Joint Commission has a whole list of unapproved abbreviations. They see that, they're going to ding you for it. Yes, ma'am.
Can you just write like Q24 hours?
You could write Q24 hours. That would be acceptable as well. Yep. All right, so again, not writing out full drug names. This has become less of an issue nowadays than it used to be, but used to have morphine being abbreviated as MSO4, so morphine sulfate, and then there's magnesium sulfate for MgSO4. So imagine you have a patient you're trying to give magnesium to and they inadvertently get morphine. It's going to be a problem, right? Or if they need morphine really bad and you give them magnesium there, they'll be feeling too much better, right? So again, write out drug names, try to use abbreviations as little as possible where appropriate. Okay? And again, I put up a list along with your assignment of unapproved abbreviations. If I see any of those, I'm going to count off. Okay, so don't, again, for this first assignment for pharmacodynamics, it's just pass-fail. However, I will give you feedback as if I was grading it like I will for upcoming pharm classes, right? For Pharm 1 and Pharm 2. Pass-fail now, so don't get too worried about it. If you make some mistakes, guess what? We're all human. We're all new at this. That's okay. However, in upcoming classes, I will start to count off and that sort of thing. Okay. Anyway, some other types of poor prescription writing. So for instance, if a drug has multiple strengths or dosage forms, not being very specific about that and saying which one you actually want. So for instance, with amoxicillin, there's several different concentrations that are out there. So if I write for a certain dispense quantity, but I don't include the concentration, I may get the wrong one, potentially given to the patient, and they may either overdose them or underdose them, both of which can be problematic, right? Also, don't write teaspoons or tablespoons. That is not used anymore. Just write out the number of mLs they should be using. And again, patients can measure that. Usually they'll be given dosing syringes from the pharmacy, so that way they can actually get the accurate amount. Okay. Anyone remember how much is in a teaspoon? 5 mLs. How much is in a tablespoon? You're going 15. Yeah. So again, remember, depending on where you get your spoon from, if I go to, say, Macy's and get one spoon versus the IKEA spoon, I think the Jorgen Florgen is what they call it. I'm not sure the name, but anyway, you may find that the volume is very different between the two. Right? Sorry if there's any Swedish people out there. I apologize. That's probably pretty racist, but anyway, I'm gonna cut this whole part out, so don't worry about it. Again, make sure the quantity is included. You want to be very specific about that it makes sense, right? So again, if I write for say 60 tabs, but then I'm only giving the drug one time a day, that may not make a whole lot of sense, right? Or for instance, I'm writing for a liquid, they're taking 10 mLs a day for 10 days, and I write for 250 mLs, that doesn't make sense, right? So you don't want to write for too much because that may be more costly to the patient. Insurances may kick it back. You need to make sure you're keeping everything making sense from the calculation standpoint, okay? Typically, if you write for a brand name of drug, we will replace it with the generic if it's available. The only because again, it's a cost saving to the patient. Again, remember that bioequivalence. We've shown these drugs work just as well as one another, and that's okay. However, if you write dispense as written or DAW, that means we cannot fill it with the generic. We have to do brand. It's not done super commonly, but every once in a while, you may see that being done. Again, that's how they get around that, preventing generics from being used for the brand names. Okay. Okay, here's a list of abbreviations to avoid. I mentioned like the UG, wouldn't write that. Just MCG is a lot easier way to differentiate micrograms from milligrams. Some of these you're like, why would anyone get these two mixed up? The answer is someone's had it mixed up at some point, right? To a point where there's a bad enough drug error, they had to actually put on this sort of list here. So again, always be careful. Let me see some other good ones like IU international units. Again, if you miss that, that could be IV potentially or 10. So again, that could lead to some major errors there if you're giving the drug via the wrong route or something like that. So again, avoid these. Again, that is uploaded along with your assignment, so you can review that as well. Okay. Usually you want to avoid just writing out take as directed, because again, if the patient doesn't remember how they were directed, they can not know how to take the drug effectively, right? So for instance, if you just write, or when we see take as directed, guess what goes in the bottle? Take as directed, right? Because again, we're trying to take down your prescription and convert it onto that bottle essentially. So it just says take as directed, and they don't get any information. It doesn't really help them. There's some instances where that's appropriate. So for instance, with this like methylprednisolone dose pack, so like a Medrol dose pack, it's very explicit where it tells you on day 1 take these 6 pills, on day 2 take these 5 and 4 and 3 and 2 and 1. That's okay. You can write something like take as directed, but usually you want to be more specific. So for our purposes, for these assignments, write it out. Just say you're taking 1 tab daily. Whatever happens if you just write it out. Some other issues you run into. So, and again, these are more kind of like emergency medicine, ICU sort of specific examples, because again, that's my background. You hear people say, give them an amp of calcium. Okay, for one, we're not really using ampules anymore, we're using these vials here. But if you say calcium, well, guess what? We have 2 kinds of calcium that we usually keep in these code cards, right? So if a patient who's like actively dying and you're trying to give them some calcium, well, do they want the calcium gluconate or do they want the calcium chloride? And we know the difference between these two? Besides the salt form itself, you're going to find that they both come as a 10 ml vial. They're both 10% solutions. They look almost identical. However, they're not identical as far as the amount of calcium, the elemental calcium that's actually in them. So for instance, you actually need 3 vials of calcium gluconate to get the same amount of elemental calcium that's in the calcium chloride. So if someone says, hey, give them an amp of calcium, I give the calcium gluconate, they may be only getting 1/3 of the dose they're expecting to get. Okay, so again, those are things that to be really careful of. Make sure you're talking very specific. So say I would like 1 vial or 10 mLs of calcium chloride. Okay, give them an amp of bicarb. I hear that very frequently as well. So again, there's 2 main types of bicarb you're going to run into. One's an 8.4% solution. One's 4.2, made for infants. This one's 1 milliequivalent per ml concentration. This one's half. So again, if I give a baby the 1 milliequivalent per ml concentration, that's going to be a very different sort of dose. Or these pre-filled syringes, this one's 50 mLs, this one's 10 mLs. So again, you can find there's big case for dosing errors that can occur here, especially if you're dealing with pediatrics on a routine basis. And then not being specific with units. So again, some people they're hypotensive with them. They'll start them up on a drug to get their blood pressure up. They'll say, hey, start them on 20 of dopamine. 20 of what a dopamine? 20 milligrams per hour, micrograms per kilo per hour, 20 ducks. I don't know what you're talking about, right? Because you can, if you get these units wrong, you can really infuse either too much or too little in that patient and lead to either worsened hypotension or hypertension. A drug we'll sometimes give for patients who are hypertensive is nitroglycerin to try to get their pressures down. That is one that has multiple units associated with it. And so I've seen them start a patient on nitroglycerin at the wrong units and basically drain the entire bottle within a 5-minute period. Patient got profoundly hypotensive, we had to give them some fluids to reverse it, but it's because the units were done incorrectly, right? So again, they were supposed to get so many, say, micrograms per hour, and they did mics per kilo per minute or something like that, and got it really screwed up. Looking at the actual inappropriate drugs that you're prescribing. So again, looking, cognizant of contraindications, the interactions that can be happening between drugs for your patients are important to know. Make sure you get a full med list from your patients, especially herbal supplements and over-the-counter stuff, to make sure you don't have any interactions there. I mentioned, a lot of herbal supplements are actually very potent drugs. Things like St. John's wort for depression. If you mix those with other antidepressants, you can run into some big issues like serotonin syndrome. So you want to get all this information there, right? Also, things like certain drugs are just not compatible together when you put them in a solution. That can be problematic for the patient. And then just looking at things like disease state interactions. Again, some drugs may work better or worse depending on the disease states the patients are dealing with as well. Okay, so compliance is what? Yeah, is the patient actually taking the drug like they're supposed to, right? So again, also referred to as adherence. How adherent are the patients to the medications? And again, you're going to find there's kind of 4 types of non-compliance, right? So again, there's going to be patients who fail to obtain the medication. Anything that could occur? Too expensive, they can't pick it up, right? Or maybe there's a drug shortage, or maybe there's some other issue where they can't obtain the medication. How about the patient fails to take the medication as prescribed? They forget, or they misunderstood you and you actually prescribed it in the first place. That could all be reasons why that. How about prematurely discontinuing the medication? Yeah, maybe they feel better and they stop taking it. Good. What else? Could be the flip side of that. Yeah, they take it. They may feel like it's not working, right? So there's some cases like antidepressants. Antidepressants take like 4 to 6 weeks before they really start to kick in, right? So if I'm depressed, I'm taking sertraline or Zoloft for that, and I don't see any difference within 2 weeks, I'm probably less likely to continue on that drug. I'm like, what's the point? I only have side effects from it. Or the other thing that can happen is the patient has 2 bad side effects and they say, I'm just going to and stop it altogether, right? So for instance, do people normally experience side effects or symptoms of hypertension? Not normally. Normally you feel fine. It's a silent disease for the most part, right? However, if I take a medication to lower the blood pressure and I start getting, say, a constant dry cough, that's usually a lot worse than the actual disease was in the first place for the patient. The patient may just say, I'm just not going to take the drug, right? Then, of course, they may come back to you and you ask, are you taking a drug like you should? And they say, why, of course I am. Why would I not take that? Why would you be suspicious of me? Right? Those are things that patients can do. That's intelligent sort of non-compliance. Or a patient may be taking the medication inappropriately. How could that occur? Yeah, someone's like spraying the albuterol on their neck, maybe.
Or taking the antibiotics at a different, like you stopped your dosage and then 2 years later you take.
Yeah, so I have some extra Cipro laying around, so I'm just going to take it anytime I feel like you have a UTI coming on or something, or lots of different ways it can be inappropriate. Some of it is going to be kind of for abuse purposes, where they're trying to abuse it maybe to get high or something. There's lots of different reasons why you may find medication being used inappropriately. So again, about a third of patients never have their prescriptions filled. I used to get so angry back when I was a young, naive pharmacy intern when I'd be working at the CVS and people come up and they have a prescription from the ER for hydrocodone, acetaminophen, the opioid with Tylenol, and an antibiotic for their tooth pain, and they say, "Don't fill the antibiotic." I'm just like, "You don't want the antibiotic?" "Yeah, I just want the Lortab." You get so mad about that, but patients do it all the time, right? There's lots of prescriptions that never get filled, whether due to intentional purposes like that, or in cases where the patient can't afford it or they can't find it in the first place. So there can be lots of difficulty associated with that, right? So the drug shortages, time of day potentially, if they don't have any 24-hour pharmacies around them and they get sent out from the ER in the middle of the night, they may not have access to anything, right? Or they may have a kind of a lack of perception of need for the medication. So in that case, the person's like, I actually didn't have a toothache in the first place. I was just trying to get opioids, and I'm not going to fill my antibiotic, right? Not that I'm cynical now or anything, but Anywho, again, when patients failing to take the medications prescribed, again, consider, is it the wrong dose they're taking, is it the wrong frequency, the wrong route. I've had patients who, there's an inhaled drug called Spiriva that comes as a little capsule, and you put it in this little inhaler and you puncture it, and then the patient inhales it. I've had so many calls to the poison center, people who accidentally swallowed it because they just took it with all their other drugs. So lots of wrong routes that can happen there. Wrong technique, so we mentioned the inhaler on the neck is probably not going to work too well. And again, do they actually understand the actual communication, the education provided to them? So for instance, if you ask somebody like, take 2 tablets by mouth twice daily, what might they think? Okay, yeah, maybe I take 2 tabs in the morning, 2 tabs at night. Or they may think, okay, I'm taking a total of 2 tabs. I'll take 1 in the morning, 1 at night. So again, having them teach it back to you is always the best way to try to see, are they actually making those connections there? Are they actually understanding what I'm saying? Okay. Again, patient can prematurely discontinue medications. All those reasons we already talked about. They feel better, or maybe they don't feel anything at all. That's why it's good to educate them on, like, okay, this takes 4 to 6 weeks. You got to stick with it for this period of time to see if it's actually going to work for you or not. Or even though you may feel better in 2 or 3 days, you got to continue out the whole course. Otherwise, you're going to get resistant bugs and potentially lead to another course of antibiotics you need for that. Right. Again, if they're taking it inappropriately, a lot of times, especially with older patients, they're usually on a pretty fixed income, and so they can have issues where patients are sharing medications amongst one another. So there's like, yeah, I had that UTI last week, but I have a bunch of Cipro left over. You want to go ahead and use this? And you have patients taking drugs that you have no idea about at this point, right? And of course, medication abuse. So again, if they're on a controlled substance and they're taking it inappropriately, that could be another thing you can run into, right? So, briefly about controlled substances, we mentioned these are drugs that have abuse potentials. These are drugs that are potentially addictive, right? And when I say addiction, anyone know what that means? It's kind of use despite like negative outcomes or negative harm, right? So again, if I am trying to decide, do I want my heroin or do I want to feed my kids, heroin's going to win out, right? Because I'm addicted, right? Those are the cases you run into in those situations, right? So again, addiction despite kind of the negative consequences. And so these are drugs that have an addiction potential as described by the DEA, right? And that's the Drug Enforcement Agency. Is that a federal or a state organization? That's federal, right? So again, remember when we're talking about differences in laws, typically go to whichever one's stricter. We'll talk about one specific case where that's not the case in just a minute. However, to prescribe drugs that are controlled substances, you need to have a DEA number, right? So again, you would, and again, in Florida, PAs always prescribe controlled substances? They couldn't for a long time, right? Florida's kind of backwards in a lot of things. It takes us time to get up to speed. And so now you guys can, but you still have to apply for the DEA license number. And again, it's one of those things where you have to do like certain continuing education credits and all these different things, hoops to jump through. But you need that number. Otherwise, we're not going to fill it at a pharmacy, okay? Now, there's 5 categories of controlled substances. Basically, 1 is going to be the highest. The big differentiator between Schedule 1 and Schedule 2 is that this has no acceptable medical use. Okay, so anyone know an example of a C1 substance? Heroin is a good one. Because again, there's no medical use for heroin that we have. Any other ones? Marijuana is actually a Schedule 1 substance, right? Even though you think of the addictive potential of heroin versus marijuana, you'd probably think which one's more addictive. I'd probably go with heroin, right? So again, but still, marijuana is considered to have no acceptable medical use. So federally, it's considered a Schedule 1 substance. Okay, so there's that. C2s are going to be drugs that have the highest abuse potential, but are going to have an acceptable medical use. Okay, we'll look at some examples of these in just a minute, and then further on down, 3s, 4s, and 5s are going to have lesser and lesser degrees of abuse associated with them, less likely to have big issues with addiction. Okay, it's still there, but lesser so. Okay, so look at some examples. And again, just so you know, there's going to be further restrictions on these prescriptions. So what you're going to find is that based on the Florida laws, you need to have the full name and the address of the patient, or if it's an animal, because again, animals sometimes need controlled substances. So animals like seizure disorders that require things like phenobarb. The owner of the animal has to be on there. Okay. And you should specify the species as well, whether it's a dog or a fish or whoever it happens to be. I've never had a fish controlled substance, but dogs certainly. And then you have to have the full name and address of the prescriber along with the DEA numbers. That has to be included there. And again, this is the one we actually have to write out textually how much you want to fill, because otherwise patients can come in after that 10, write an extra 0 or 2, and then they're getting a boatload of drugs they were not prescribed, right? So Schedule 2 substances, you'll find that Schedule 2 substances have the most restriction on them. Obviously, Schedule 1 we're not going to be prescribing, but Schedule 2s have the most restrictions, and then 3, 4s, and 5s kind of get lumped together to some degree. But basically, for Schedule 2s, you can only write up to 90-day supply. Typically, though, you're just going to write month to month for a lot of these, just 30 days at a time. And they have to be on prescription paper that is going to be obvious that the patient's copied it. Usually, like, they'll copy it and it'll say void, void, void all over it. That way we know, that way the patient's not taking it to every single pharmacy out there and filling it, right? These also cannot be transmitted over the phone. So they actually have to bring us the paper, the hard copy prescription, us take it, and then we can fill it, okay? The other thing with 3s, 4s, and 5s, they're only good for an amount of 6 months. So you can only write for a 6-month amount for them. Otherwise, they become invalid. As opposed to non-controlled substances, we said, were how long? Like 1 year, right? So that's a big difference there. Yes, ma'am.
Can a pharmacist refuse to fill one of these scheduled?
I can refuse to fill anything I want. That is my prerogative. That is not good business typically to do so, or ethical in a lot of cases. However, I'm sorry?
Do they have to inform the person they refuse?
Yeah, so because otherwise they're going to be waiting there at the counter about, where's my drugs? And then you're going to be like, there's no drugs for you, right? Yes, that does need to be stated there. Yes, any pharmacist can refuse. I've had some guys who say, I'm just never, they're usually the older school guys, they're like, I'm just never, ever going to fill a C2, ever. And it's like, how can you just say blanket, you're not going to do anyone, right? So again, it depends on where you're working and all of that. But yeah, it's certainly a sort of moral, ethical sort of quandary whenever you just decide not to, fill something, right? Just like some people have said, I'm not going to fill emergency contraception, right? I'm not going to fill a Plan B because on moral grounds or religious grounds, whatever it happens to be. But yeah, any pharmacist can refuse to fill any prescription they want. It's just not done very frequently. Do you have a question?
It just happened recently.
Which one? The controlled substance or the emergency contraception? Yeah, I mean, and to be fair, like, that's one of those things where we have issues where, like I mentioned my second day interning at CVS, we got held up at knife point for Lortab. I mean, it was a guy who, when they finally caught him, he left like an infant at home by itself while he was out stealing this Lortab from the pharmacy. And I mean, it's incredible what people will do when they're truly addicted to these substances. It's a pretty sad sort of thing. We're in the middle of this opioid epidemic. But some people do it because they're like, well, I just don't want those kind of people coming here. I just don't want to do it. And so they just make a blanket statement. I would say that's probably really inappropriate. But everyone's a little bit different when it comes to that sort of thing. But we had a big issue. So, for instance, if you call a pharmacy and say, hey, do you have this controlled substance in stock? What do you think a pharmacy is going to tell you? Yeah, either I can't tell you or we're out of stock. To say we don't, because again, you worry about people coming trying to rob you, right? So we were running this issue where basically we had a lot of kids who were being discharged from our surgery department. Basically, they had either tonsillectomies, adenoidectomies, whatever, they're coming out, and they had a prescription for a controlled substance. But kids, I mentioned, can they take tablets? Not usually. These little kids, they have to take liquids. Well, so there was one that we were using called Hyset. It was hydrocodone and acetaminophen. And it's something where a lot of normal pharmacies do not carry that because it's just not prescribed very often. So if you're not going to use it, why keep it on your shelf? So we had these kids who are coming out of surgery, and the parents would say, hey, do you have this drug in stock? And then the pharmacist would just say, no, we don't have it. And so now you have these kids who are in pain after surgery trying to go around to every single pharmacy to try to find someone who actually carry it. And it actually was a major patient detriment, right? So it's one of those things where there's all kinds of, it's kind of a sticky wicket in a lot of ways, and can be kind of an issue there. So we had to find specific pharmacies that we communicated with and say, hey, if we send our kids your way, will you stock this? And they said, okay, yeah, we'll stock it. And they were able to fill it. However, it took a little bit to get to that point. So it can be kind of a big issue there. But again, patients who have a legitimate pain need, like they need these meds. It's just no two ways about it, right? Right, so here's an example of like prescription kind of counterfeit proof paper. Things if you try to copy it, it will just say void all over it. So that's one way we try to get around some of that. And again, it has to be hand signed by the prescriber, especially for C2s. That way we can make sure that no stamps, no electronic signature. It has to be handwritten for C2 specifically. Okay, and then and for C2s, we cannot communicate that electronically. Sometimes you can call in things like C3, 4, or 5, but C2s have to be all on hardback, essentially. Okay, so let's do a controlled substance quiz. Let's say, federally speaking, morphine. What schedule do you think that falls under? Yeah, it's actually a C2. Good. How about cocaine? Ooh, it's actually a 2. We used to carry cocaine at our hospital for a short period of time. Our ENT docs would sometimes use it. It's a very good numbing agent. It's a very good vasoconstrictor. We would sometimes use it for ENT procedures. They stopped using it, so we got rid of it. How about methamphetamine?
But it's still class 2.
Yeah, it's still class 2, so there's still acceptable medical use for ENT procedures. It just may not be used very frequently, right? How about methamphetamine? Methamphetamine is actually a 1. However, there's lots of amphetamines that are 2s, right? So for instance, all your Adderalls, your Concertas, your Ritalins, those are all amphetamines. However, they are classified as C2. So there can be some differences even within the same class, right? How about marijuana? Still a Schedule 1 substance. So I mentioned, usually you go with the stricter law. However, are we doing that everywhere? No. So again, states are now taking it under their own means to make it either recreationally available, and again, the number of states where that's been decriminalized is growing, and then also for medical use. So again, remember Morgan & Morgan? He was really big into getting medical marijuana approved for Florida, and so now we have that available, right? So again, it's very highly restricted. However, you do have that avenue available if your patient is a good candidate for it. We'll talk about that when we get to talking about pain management stuff in Pharm 2, I believe. We'll talk all about medical marijuana there. It's a very interesting kind of topic. Anywho, so again, you may find in certain states, certain drugs are controlled substances, whereas they may not be in others. So for instance, there's a drug called carisoprodol. The brand name is Soma. It's actually a Schedule 4 substance in Florida. If you go elsewhere, you may find it's actually not controlled at all. So it just depends potentially on the state. And again, go with whatever's more strict in most cases. Recent changes, for instance, we did tramadol, which is kind of a weaker sort of partial opioid agonist, actually got changed from unscheduled up to a C4. And this is a big deal because at the time, PAs could not prescribe for controlled substances, so this is a good option for more minor pain concerns. You could do tramadol, it wasn't an issue because it wasn't controlled. Now they saw enough people abusing it to where they say, okay, well, let's go ahead and make it a C4. And the other big one was hydrocodone. This is the #1 prescribed drug in America. Moved from C3 to C2. And along with it, had so many more restrictions placed on it. And so, again, you're going to see that actually have decreased trends in prescribing for that because it is more difficult to get a hold of nowadays. But that's another big change they made there. So, anyways, is there any questions on that? So again, go through, when you're doing your prescription assignment, again, try to be diligent. Go through the rubric. Make sure everything that I'm taking points on there is present there. So your name, address, the indication, all that good stuff. And that's the way it should go, right? Any questions? I will see you guys next time.